Hi, everybody. Welcome to Friday conference. Let me just pull up the slides and we can get started. Okay, great. So welcome everybody to our CFAR conference. Let me just pull up the chat window. Okay, great. And so that anybody has any thoughts or feelings, they will feel free to express them either by chat or by unmuting. There is always fine. And so today's topic, we're going to talk about some updates from CROI. And then just in terms of upcoming conferences, what we have in the next few weeks. So we have weight management next week. I think this will cover both pharmacologic and other options for weight management, but in particular pharmacologic. And then on the 12th of April, we'll have some Bartlett cases and updates from Bartlett with Sheila and Stephanie. And then also we'll do either a case or some overflow from CROI. On the 19th of April, we are very fortunate to have Debbie Prasad is going to come and present for us some of the data that she just presented at CROI on the really exciting things going on in pediatric cure research. So look forward to that. She's probably her talk is relatively short, so we'll leave it plenty flexible for her to either take up the whole time or else there's always more things to talk about from CROI, so we can fill in the end of that space if needed. And then on May 3rd, just to highlight again, we're going to have our in-person and online hybrid HIV cure with Dr. Bob Silcano on that day. So before we get started, I'll just acknowledge, so I do some CROI reviews with Paul Sachs, and so a lot of these slides are built either from slides that we both made and used or that one of us used in our presentations. And of course, discussing these topics with him is always informs part of how I think about what we're talking about. So just want to make sure to shout him out. Okay, great. So I thought I'd start off today with a little bit of COVID. I don't think Amy Antar is here, but if she does join us, she can certainly comment on this. She gave a really nice presentation at the meeting about long COVID. But I thought I'd just highlight a few things that I thought were interesting and still clinically relevant for as we think about in the clinic. So the first two are a pair of vaccine studies. So this was a VA study looking at COVID incidence and severity in persons with reinfection versus post-vaccination breakthrough infection. And they compared the incidence of hospitalization or death within 28 days. So they had two groups, individuals who were vaccinated but had no history of infection and who developed a breakthrough infection, and then an unvaccinated group who had previous known infection and then developed a first reinfection. And so they defined a breakthrough as a first confirmed infection more than 14 days from the last vaccine dose in individuals who had received at least 2 doses of the mRNA vaccine platform through the VA. And then reinfection was confirmed a COVID-19 infection more than 30 days after a confirmed prior infection in an unvaccinated individual, and their primary outcome was hospitalization or death. The individuals in the unvaccinated group, which was the smaller group, were matched 1-to-1 with the other group based on a lot of things. So age, race, sex, a bunch of comorbid conditions that may have had impact, including diabetes, CKD, stroke, BMI, and then the calendar quarter of infection and geographic location, which is also, I think, quite useful that they did that. And then this was their findings. So in about 13,000 individuals, which was their cohort, they were primarily male and older individuals, it being a VA cohort, so not surprising about that. The rates of breakthrough infection, interestingly enough, were similar in this cohort. And for the primary outcome incidence of hospitalization or death at 28 days, if you were vaccinated and had a no history of infection, the incidence of that outcome was 4.69. And if you were unvaccinated and had a prior infection and developed a first reinfection, the incidence was 7.31. So overall, this study, I think, suggested that vaccination was better than prior infection in this early part of the epidemic. I think one of the things that's very hard to control for in this particular study is who and why people choose to be unvaccinated and whether or not that has certain health behavior associations that might bias you towards having a severe outcome from a reinfection. I think one way they could look at that, and I'd be interested if others had thoughts on this, but would be to look and see whether the first infection was of a similar severity level, because that would argue that it was sort of inherent to the host as opposed to the immune response per se. But I don't believe that they did that particular analysis. And then before I pause to get comments, I'll just present the second study also. So this is the Ubuntu study. This is an mRNA vaccine compared to hybrid immunity against COVID-19 among people with HIV during the Omicron wave in sub-Saharan Africa. So the sites are listed here: Kenya, Uganda, Malawi, Zambia, Botswana, Eswatini, and South Africa. And they defined hybrid immunity as evidence of prior SARS-CoV-2 infection and then receiving a single dose of an mRNA platform COVID vaccination. And vaccine-based immunity is at least 2 doses of an mRNA vaccine and no prior SARS-CoV-2 infection. It was an open label, multi-center mRNA vaccine-based study in people living with HIV in Eastern and Southern Africa, and enrolled people at high risk of having severe outcomes. So in particular, those with HIV. And here there were no exclusions for other health conditions, including pregnancy, HIV status, treated or untreated, CD4 count or ART use. Now, individuals were assigned to these 2 groups, either 1 dose of vaccine versus 2 doses of vaccine, based on a point-of-care serology test that detected evidence of prior SARS-CoV-2 infection. And when they did a later analysis where they used more sensitive laboratory-based testing to try to sort out prior infection, if they identified people who'd been randomized to the 2-dose vaccine, but who did have serologic evidence of prior infection, they excluded them from the analysis. So actually did take that sort of second step of trying to really look at the question, at least based on to the limits of that serology can provide. And so what were their findings? So they likewise had a large study, greater than 11,000 people living with HIV, including 6.6% with a CD4 count less than 200, and about 18.5% with a viral load greater than 50. They only had 358 COVID-19 infections, no deaths, and only 15 severe cases. So that actually, to me and to the study authors, I think was the most surprising finding of the study. But their findings in terms of immunity, vaccine versus hybrid, was that hybrid immunity was associated with a significantly lower risk of COVID-19, 42% lower adjusted hazard ratio, and a lower risk of severe COVID-19 with a 73% lower adjusted hazard ratio versus vaccine immunity among people living with HIV. And a subset, they also did some studies on a subset of participants who had very prolonged nucleic acid testing positivity, and that was more common, so more than 50 days in a subset overall, and then 19 participants had positive antigen detection for more than 100 days among all people living with HIV. So a rare, and this is a very large study, but still with 358 cases, but 19 of them with very prolonged detection. Among the people with HIV who had this prolonged positivity, it was more common in a setting of a history of TB, detectable HIV viral load, or a CD4 count less than 200. So just to put these 2 things together, I think, the first study suggests that vaccine is better than infection in the VA cohort. That has the caveat that people who don't get vaccinated may in fact be slightly different in terms of health behaviors or other comorbidities. In the sub-Saharan African study, a mix of vaccine and infection was better than vaccine alone, in particular in people with HIV, which was who the study population was predominantly. That study potentially could be confounded by the fact that this was the Omicron wave, and it's possible that people who were going to have a very severe outcome had already had that with their prior infection. And so by including those who'd already had an infection and done reasonably well, you were sort of pre-selecting a group of people who were more likely to do a little bit better with a secondary infection. So a different kind of potential bias. Rates of infection were very low in the Ubuntu study, lower than predicted, given the preferential enrollment of people at risk, and don't really know exactly what that means. But moving forward, I think the question of these different variants and some of the work that people like Joel Blankson and others have done is how do we assess the impact of shifting variants and what features of the immune response are most important to identifying who needs more vaccines and when. And what do you do in terms of vaccination if someone has a recent history of infection, and how many doses of this vaccine are we going to give? I noticed this in particular because I had a patient in clinic the other day with fellow who was triggering an alert that he needed an additional dose of the COVID vaccine. but it didn't feel necessarily like sort of local evidence-based to administer a COVID vaccine at this moment. And, the patient wasn't actually that interested in it, but I actually was, interested to know if other people have thoughts or about how they're currently thinking about counseling around vaccination for COVID. See, if there's anybody who wants to speak, you can certainly do that. We'll just wait a moment. Okay. So then the other thing I was going to talk about from the COVID space was this looking at an interesting study that Annie, I believe, has collaborated on, which is looking at long COVID in this LINK cohort. So this cohort was established at UCSF. Michael Peluso from the Division of Experimental Medicine presented this particular study. So here they were looking for evidence of SARS-CoV-2 persistence. And he introduced the talk saying that, at the beginning of the pandemic, when people asked him the difference between HIV and COVID, he would say, well, COVID goes away and HIV stays. And so this is sort of a follow-up of that question. And, is there SARS-CoV-2 persistence? Does it drive prolonged sequelae or inflammatory sequelae? And how can we sort of figure that out? So there is some evidence. There's a Nature Communications paper that summarizes a lot of different studies, but these are all limited by small cohorts, limited follow-up time, and a lack of vaccination status information. And in this particular cohort, they have more than 1,000 participants. They started enrollment very early in the pandemic in April of 2020, and they have more than 4,000 visits with these participants, and about 77% of them, I think, are pre-vaccine. So yes, so what they also have included, because they leverage the infrastructure for the scope and options cohorts, which have been following people living with HIV for a long time, they have 250 pre-pandemic controls to use as true negatives. So there is no way that you should be able to detect COVID antigen in these samples. So it's a nice validation that if you see something, you can actually say something, as opposed to attribute it possibly to false positive detection. They had 172 post-COVID individuals, which had a total of 661 time points, and they looked at 3 to 14 months post-infection. As I mentioned, most are prior to COVID vaccine, and they had no documented reinfections in the study, although that's very difficult to formally rule out. So they used a Simoa platform, which is a single molecule array assay, very sensitive for rare detection of a very low concentration of protein, and they were looking for spike S1 and nucleic capsid. So what did they find? So if you look here in the blue, these are their pre-pandemic negative controls. And in their negative controls, they have a 2% rate of detection of SARS-CoV-2 antigens. So that is your false positive rate, which is useful to have. And then they look at their follow-up visits, and these are all from plasma. And at 3 to 6 months post-COVID, about 13% of individuals have detectable SARS-CoV-2 antigens in their blood. At 6 to 10 months, that drops to 11%. And then at 10 to 14 months, they see it at about 7.4%. This is about 2 times higher prevalence detected versus undetected in those who are hospitalized versus non-hospitalized. The P just reaching significance there. And among those who have self-reported severe COVID as their non-hospitalized episode, there was a higher prevalence of detection, although the P is not exactly significant there. So I think, again, using pre-infection controls, they next analyze gut specimens. So they work with GI Dr. Masumsuk, who's done lots of work in HIV. And they, with that study, were able to visualize spike protein in the gut samples up to 2 years post-COVID. Again, mounting on the same slide samples from their pre-COVID negative control and their current cohort. It is very challenging to rule out that there's been an asymptomatic reinfection, and thinking about antibody titers or other indicators might be useful. So I think the implications from this, it's relatively strong data to support that at least for some people, there's persistence of SARS-CoV-2 antigen in immunocompetent individuals. It's unknown whether this has any relationship to the post-acute sequelae of COVID or of SARS-CoV-2 or to complicating medical events like myocardial infarction or clotting events. And, one possibility is to target viral persistence with mechanistic studies using antiviral agents to see if the overall outcomes can be improved. And then the other question is whether this is an isolated COVID phenomenon or one that we have just not appreciated fully in the setting of other viral infections. I think one challenge to this suggestion of looking at viral persistence in mechanistic studies is that for individuals who have serial samples, it is not the case that the same individual will always be detectable or will always be undetectable. There's some variability in detection. And so being able to, one would have to very efficiently eliminate the signal in order to demonstrably show that an intervention caused a decrease in RNA or protein detection. So that may be a bit of a challenge, but I think, this is a robust cohort to look at some of these questions, and hopefully we'll get some more information from people like Michael in this group, and also Annie and all of the studies that she's been doing with samples collected here and elsewhere. Anyone with comments or thoughts on that? Again, feel free to either put something in the chat or raise your hand, or just unmute and interrupt me. I love that, actually. If not, then I will roll over into some of the more traditional HIV-focused studies. So this was the CARES trial. This looked at cabrolpivirine in sub-Saharan Africa. And so there were two possibilities. You were on greater than or equal to 18 years old, stable oral therapy, HIV suppression for the 4 to 12 months prior to enrollment, and then again at screening, no history of treatment failure, and no hepatitis B infection. And so with those criteria, they enrolled a cohort that was 57% female, ART duration a median of 8 years prior to enrollment. 92% were on TLD, which is tenofovir, lamivudine, dolutegravir, which is about probably the regimen for about 20 million people at present. And 74% had prior NNRTI regimens, and that point becomes of note as we walk through the data. So with this cohort of 256 people in each arm, you either continued on your oral standard of care regimen, which is either TDF plus FTC or 3TC, you're abbreviated by me as XTC, plus dolutegravir, efavirenz, or nevirapine, depending on country standard. And then the other arm was optional oral lead-in for cabrolpivirine or progression right to cabrolpivirine IM injections, which were administered every 8 weeks. The primary endpoint of the study was at week 48, although the study extends out to week 96, and they will report the week 48 results here at CROI. They did stored PBMCs at baseline for proviral resistance testing subtype assessment, and all of that is batched and retrospective, not impacting the randomization at the start of the study. So in terms of their primary endpoint at week 48, they had 97% suppression on oral standard of care and 96.9% suppression on cabrolpivirine. They had 1 confirmed virologic failure on long-acting cabrolpivirine and 1 unconfirmed failure due to an HIV unrelated death. And interestingly, so that's about the rate I think that we would predict based on lots of prior studies, even with perfect adherence. The thing that was really like the sort of notable thing about this study was that they did proviral resistance testing, as I mentioned, and 10% of the participants had some evidence of rilpivirine resistance and 8% had some evidence of cab resistance. The other thing that was quite notable about the study is that they monitored viral loads every 24 weeks. So this is every 6-month viral loads, even after initiation of this change in regimen. I think really to try to achieve a model of what this would look like in real world implementation, but requires some nerves to do that. So I think what is the importance of this study? It definitely expands the base we have of data for cabrolpivirine to a different setting in a, less with very, as one would say, sparse viral load monitoring. There were high rates of obesity in the study, which also has been thought to be a potential risk for treatment failure. Population very common to have prior NNRTI exposure, and it's really not clear what to do with the proviral DNA resistance testing. It's definitely not ready for generalization. I think it's notable, and I will mention here that rilpivirine resistance was among the predictors of failure in Atlas and FLAIR. So it's not that we don't have data to say it does matter. We have data to say it does. We have positive data suggesting that a history of resistance matters. It is notable that it exists in this study, and we'll sort of circle back to proviral genotypes a little bit later in some of the other things that were presented, but an interesting study with certainly lots to add. Randy, did you accidentally put on your camera, or did you want to say something?
I just had a question.
Yeah.
For these resistance genes, did they clarify like it was with the detected mutations that there was no predicted rilpivirine activity, or
So
just
that's
any potential mutation?
Yeah, that's a great question. And so the resistance mutations are not specified in the presentation, and also the relationship. I mean, they only had the one failure, so I don't know. I can't remember actually if they specifically said that that individual had a resistance mutation. If anyone else remembers, please feel free to unmute. But I think that's really going to be a devil is in the details. Kind of a study. And Liz is asking the very important question about loss to follow-up, and I actually don't recall that. I think overall, with the FDA snapshot, there was slight differences in sort of regimen failure, confirmed virologic failure, and treatment failure, but they were very, very similar across all three measures. So in general, it was successful at week 48. And that should account for some of those things, right? That unconfirmed virologic failure, the HIV unrelated death was obviously a study loss. So still some more things to sort out, but similar to the rates of success that we've seen previously with about a 1% failure rate, even with on-time injections. There were a couple of studies that I don't have details for, but I did put the abstracts here below about looking at cabrolpivirine in clinical practice. So in the OPERA cohort, there were 25 out of 1,200 who failed cabrolpivirine, consistent with their also standard oral ART. So on the poster, they have the rates of failure and showing them that they're the same. Although presumably the reason for the failure is different in these two, right? Because in the oral ART, there's still always a possibility that, in fact, the mechanism of failure is lack of full adherence, whereas in cabrolpivirine, even with adherence, there is this low but demonstrated failure rate. In the TRIO cohort, they had 2 out of 278, or 0.9%, again, nearly exactly that 1% rate seen in the clinical trials. And then there was a one-site experience that was reported with a very high rate of failure, 3 out of 75 patients, all of whom were transitioned to boosted PI regimens with suppression. And 2 of the failures were described as being thought to be related to, quotes, non-standard injection practices at the site of med administration, which was not on site at the clinic. This was notable to me just in that, I know Ethel, and we're going to have her come in and show us this data at some point, has previously shown that even under ultrasound guidance, where these medications actually go is not necessarily as one would predict. And this does give me some pause I had a patient who was going to have trouble getting to a clinic and was going to try to maybe set it up at a local pharmacy, but in the absence of knowing that there's good experience with injection, I am not sure that I would feel super comfortable with that. And this one site anecdotal experience would probably be supportive of that. I think there was also a 24-week update, yes, from the Ward 86 experience, which we heard about in detail when Monica Gandhi was here. But just to highlight here, so this is 59 individuals who started long-acting cabrolpivirine with a viral load greater than 50 copies by December 5th of 2022. So unlike some of these other, sorry, let me just, sorry, I'll just stop for these questions and comments before I roll through. Yes, the KIDIO study really does support the feasibility of that injectable ART in sub-Saharan Africa, as Yuka is saying. And in the prior large cabrolpivirine study, so meaning
the one from sub-Saharan Africa.
Oh, the sub-Saharan Africa. So they excluded Hep B.
So even anti-core or just surface antigen?
So that's a good question. I don't know. I don't recall from the presentation, if anyone does, how they actually defined Hep B status here. And they were, as you point out, all on Hep B active regimens at enrollment.
Yeah, thanks.
And then Sarah Rivas, is there a standardized way of defining failure on cabrolpivirine? So this is a really important question. And I think, so in the Ward 86 experience, where they're reporting on these individuals who have virologic failure, if you look in the chart, there's a couple of them who have sort of low-level viremia and, are still meeting definition of virologic failure, but aren't necessarily like are probably still benefiting from the treatment. And I think that's a really important question. And Sarah, I'm assuming you're thinking about patients who are in the like 100 to 400 or even 1,000 range, but are better than they ever were before. Yeah. So most of them are documenting, like here, CD4, the suppression is by viral load local standard. So in most cases, less than 50 copies. So this is the 24-week update from Ward 86 of these 59 individuals. Just to remind us all of the demographics, 8.5% female, 40.7% white, 53% or so unstable housing or homeless, 61% with active meth, cocaine use, and 10% with opioid use, and a CD4 count of less than 200 in almost 50%. And 86% have a viral load greater than 1,000, and 70% with a viral load greater than 10,000. And this point, it just becomes important because for some studies that are looking at viremic start of cabrolpivirine rather, they're looking at greater than 50 copies. But I think we would all agree that 100,000 feels different than 200 copies on an oral regimen. So here are their results. So 48 out of the 59 are still on long-acting cabrolpivirine with a viral load less than 50. 55, and so here they specifically say, Sarah, to your point, 56 out of 59 are still virally suppressed to less than 200 copies, either on the original or on an alternative ART regimen. And 55 out of 59 are virally suppressed. Some of them, I think, after starting cabrolpivirine, actually did change to oral therapy or were shifted to lenacapavir regimens that have led to suppression. So overall, for this group that was enrolled, they've had really outstanding virologic outcomes, of which about 81%, 48 of the 59 are still on the cabrolpivirine. 3 patients with virologic failure with emergent resistance. Again, these happen pretty quickly. 2 within 8 weeks of initiation, despite on-time injections, and resuppressed on alternative ART. 1 following a self-discontinuation who also opted not to take oral ART. So our fears that if you stop this, you will develop resistance, I think, are probably well-founded, but I'm not sure it should prevent its use in individuals who have no other options. 19 transitioned to Q8 weeks by week 48. So another question that comes up frequently, that Ward 86 protocol did start everyone at every 4-week injection. That's about 32% are now on every 8 weeks. And 17 or 29% had at least 1 injection more than 7 days late. 3 of those were lost to follow-up, and the remainder are still suppressed on long-acting cabrolpivirine at week 48. So are there any inclusion criteria that led to such low dropout rate with this high-risk population? So good question, Mike. I think that realistically, the low dropout rate here was also partially based on the intensive support and outreach that the clinic provided, which included in some cases meeting individuals in parking lots that were pre-specified with the patient in order to provide injections to people where they were. So I think that the low dropout rate here is largely based on the outreach that was included as part of the package. So I will also, the next sort of big blockbuster in this space was Latitude, which was the ACTG 5359. We did briefly talk about this a few weeks before CROI because of the DSMB stopping this study, but just to give a little more complete picture. So this is a randomized trial that enrolled people with HIV that had barriers to adherence, either poor viral response despite oral ART for greater than or equal to 6 months, or a loss to follow up with ART non-adherence for greater than or equal to 6 months. Now, step 1 of this study was adjusted during the period of the trial itself, but started out as 24 weeks. It was shortened with standard of care oral ART plus conditional economic incentives. So what does that mean? A CEI, that is you are paid for having for coming to study visits and further for achieving viral suppression. In step 2, the individuals who got to achieve the criteria of viral suppression in that first step 1 were randomized 1-to-1 to either start cabrolpivirine every 4 weeks or to continue on oral standard of care ART. And in step 3, the plan was to roll everyone over into, and that was 52 weeks or a year. The plan for step 3 was to roll people over into cabrolpivirine from both arms. So the DSMB review recommended moving all eligible participants to have the option to start long-acting cabrolpivirine before CROI. Here's just a look at the individuals who were enrolled. So 434 with a median age of 40, 88% of them were less than 30 years. They did enroll 30% female participants and included 5% on the transgender spectrum. Race, ethnicity, so they had 64% Black or African American and 17% who were Hispanic or Latino. They included current and previous injection drug use at a rate of 14%. And then their description of their non-adherence criteria. So poor response was 65% of the individuals, lost to follow-up was 20%. And I think, that speaks to the fact that if you're lost to follow-up, it's hard to enroll you in trials. And the median time since diagnosis of HIV was long, about 13 years, with a range of 7 to 21. So what did the data show? So this is the virologic failure. The difference was 18%. So the cumulative probability of virologic failure was 7.2% in the long-acting cabrolpivirine arm versus 25.4% in the standard of care ART arm. And this difference is what led to the recommendation to offer long-acting cabrolpivirine to all eligible participants. Permanent treatment discontinuation rates were lower in cabrolpivirine versus standard of care ART. And in terms of resistance, there were 2 in the cabrolpivirine arm out of 6 individuals who had failure, and 2 in the standard of care arm out of 28 individuals who had failure. So I think super important in terms of the engagement of a very hard to reach population in a clinical trial setting. It did lead to IAS USA guidance, which I will mention briefly in the next slide. And then I think one of the really interesting questions here is the role of conditional economic incentives. And, other people, I think Sunil Solomon and others have done really, extensive work in this area. I have very minimal understanding of when it does and does not work. But I will just say that I think, when you compare, so the conditional economic incentives for maintaining viral suppression were only during step 1 and not during step 2. So that is potentially one reason why there was a fall off in oral ART adherence, if we think that the conditional economic incentives were really driving at least some of the outcomes. I think, and this may be influenced by some recent podcast listening, but I think the other thing that may have impacted the success in that first step 1 is the hope. Like the hope that you were just about to get onto something where you wouldn't have to do this anymore in a population that clearly struggles to take oral ART. And so the combination of both a conditional economic incentive and the hope that in just a few months, you won't have to do this anymore, I think would be quite powerful. I'm not sure how that sort of hope part, like if you get to step 3, you can have it also, but 52 weeks is a long time, which would mean that it would be from enrollment to starting your injectable therapy would have been a year and a half. And that's a little bit longer, I think, to maintain that kind of motivation. But if anyone has thoughts or comments on how is this the model that we should be using? Should we be starting this in the absence of conditional economic incentives? How should we be applying this? And as I say that out loud, I'll just put up here, there was a letter to JAMA from the IAS USA guidelines that suggested that when supported by intensive follow-up and case management services, injectable cabrolpivirine may be considered for people with viremia who meet the criteria below when no other treatment options are effective due to the patient's persistent inability to take oral ART. And so this includes being unable to take oral ART despite extensive efforts and clinical support, so they include some HIV defining, HIV disease progression defining questions, and the virus is susceptible to both. But Yuka, I saw your hand up, so polite.
Yeah, I was thinking I'm not the right person to bring this up, but from my past experience in Bartlett, I think it's a very slippery slope. How do you decide who you're going to give economic incentives to just because this is injectable ART? You could say that about a lot of different things. And it's been my experience, and I'm sure people like Richard could also comment, and Joyce, that it's very difficult if you don't have a really strong fence around your policy, because then you don't know how you're going to apply it. And then it's not really sustainable in a way. So one of the ways I think in the Bartlett practice that has worked is to continue to be supportive of everybody in their journey wherever they are, and to try to offer a place where they really feel that they're treated the way they deserve to be treated. But beyond that, I would really worry that you couldn't put good policies in place to make it really easy to tell when you are getting out of your precedent. Yeah.
Yeah, Chris.
And I totally agree with Yuka. I was going to say something somewhat similar, but a little different, not about the cash, conditional cash transfer. Obviously in Ward 86, what they do is fantastic, but I think just from a harm reduction perspective, in patients who are struggling to take their meds, have a low CD4 count, and have a virus susceptible to CAB and ripivirine, not offering them the option of injectable and just letting them slowly dwindle away and die is has some questions and a little bit of paternalism to say only if we have this amazing support network can we offer that to you. And the patients who struggle, I don't know about for Ward 86 or the clinical trial, but are highly heterogeneous. Some certainly are the people who are very much challenged with substance use disorder, but there are many social, structural, other factors at play, and some individuals are able to, even without intensive follow-up, I'm not saying that that's not a good thing, show up for an injection every month or every 2 months, but just cannot take daily medications. And I think it's dangerous to say we'll only offer this if we can provide all of this stuff.
Yeah, I mean, I would open, and anybody else with thoughts or questions. I mean, I personally found the IAS USA guidelines update to be very encouraging, because to me, I think getting something into guidelines is a way to help move the needle from payers. And this is the population who needs this the most. I don't know that the DHHS panel will move as aggressively on this, which would fit with historical sort of conservatism versus a little bit more edgy recommendations from IAS USA, even though there's tons of shared members. But I agree with you, Chris. I think, that, and Yuka, I think we have to offer people treatment that could be life-saving. It's just, I think part of the challenge is identifying when and who, right? Like, and Yuka, to your point, for whom would we offer a conditional and economic incentive in order to basically get to meet the criteria to start the drug, right? So, and obviously that would be the endpoint for the conditional incentive, would be that you achieve the endpoint that allows you to start the medication. And I guess the question is, do we really need to do that? So that's how A5379 was done. They got them suppressed before they injected. That's where Ward 86 is very useful, because they did not achieve that before they started injections. And I think, these are really hard questions, but I think we all feel like we should be offering this to more people. Anybody else who wanted to make a comment? Because this is a great, this is a very important discussion. I will also, so that other things, did someone just
I
unmute?
wanted to ask, does anybody, with
Yeah.
the incentives, I mean, it's a really interesting idea, because this study was even when they were on oral ART, right? That they gave.
So they were
that
incentivized for the oral part.
Yeah, I'm just, does anyone, like, even in like diabetes, like, are there countries with universal healthcare that give patients incentives for like metrics?
So, Randy, I think what you're saying to me is like, we should invite someone to talk about that, because I am not the person, but there are people who have looked at this extensively. Jeannie, I see your hands up though.
Yeah, I think the incentive piece is extremely complicated, because it's the how, how are you going to do it and who is going to pay for it? Ryan White doesn't allow for cash incentives. out of Rhine-wide dollars. And our Rhine-wide dollars, our local Rhine-wide dollars are really getting taxed and reduced for like us, the state money that we're getting. And so I think that's the real issue. We'd have to really think out of the box. You know, the studies have had their payments paid through the study, but I'm struggling now to see how we would pay for cash pay. How would we pay for cash payments unless we partnered with, I don't know, industry to give us some,
Yeah.
you know, it's finding this money because it's not just the cash payment. It is the process to distribute the cash payment. It has to be monitored. The infrastructure for that is
Intense.
not without infrastructure, right? You
Yeah.
have to have the infrastructure.
Yeah, and I think Tracy AG put in the chat that like this is not new, and like other disciplines may have something to teach us, and I think that's exactly correct. So I will work on getting for one of these Friday conferences, like someone who's experienced with it, implementing it in other disease settings, could come and talk with us about it, because my understanding of it is that the literature is quite mixed. And you guys saw your hand was up again.
Yeah, there are two potential ways to pay for it. One would be to petition like Maryland PCP. Randy brought up whether or not it was possible to get adherence for other things, not just this particular issue. So I think it's possible. I think you could get philanthropy to have a time-limited thing that would recreate what has been shown by clinical trials to work and give people like a green fire card. But I wouldn't want to be in charge of that, trying to take care of petty cash here and trying to get Visa cards and things like that to work are not inexpensive and I think are an accounting nightmare. So I don't know. I think the amount of time required for the number of people that you would have, there would be a serious opportunity cost.
Well, I think I will take away from this that we have, it's worth at least a discussion about what the evidence base is and thinking about who it would be most important for. Sean.
Yeah, so like Tracy was saying, probably the strongest evidence for contingency management is for substance use disorders, specifically with cocaine and methamphetamines. There are actually some states that now cover contingency management through the healthcare system. So in the state of California, for example, you can get support for contingency management for substance use care specifically. And to your point, Eileen and others, they're specifically. But when I think about the overlap of those continue to fall behind in the HIV care continuum, I think it overlaps very strongly with the population in which we have the strongest evidence for contingency management. So like you said, Eileen, getting someone who potentially has implemented this in real world settings, which we know is not being done in some states in the US, might be helpful to everyone.
Yeah, thank you for that. And that is exactly right. This often is a direct overlap. So other long-acting strategies, I just wanted to briefly update. So lenacapavir, there's also from Monica Gandhi, who's at the forefront of long-acting in hard-to-reach populations. So there's a case series that was collected of individuals from Ward 86, UCSD, Owen Clinic, Metro Health HIV, and UPenn, and included 34 individuals, a mix of detectable and undetectable at the start of treatment. And so for this, I like actually looking at the poster, there are some people who are just totally undetectable and have been through all visits in recent history, and then are switching to Len-Cab because I think of intolerance, but were suppressed on things like Adrenavir, Cobi, FTAF. 47% were suppressed at baseline. Again, another important question as to whether or not we're thinking about starting people who are viremic versus switching people to a strategy. 76% male, 41% Black, 38% Latin, median age of 47 with a range up to 75. I love that. I love to see older individuals participating in some of these trials. And 29% were on CAB at Q4-week interval dosing. Again, another point that comes up a bit as we implement these strategies. So 94% were suppressed to less than 75. So to Sarah Rivas's earlier point here, less than 75 was the magical number after lenacapavir at a median of 8 weeks. What was not totally clear for me was the duration of follow-up. So I don't really have a good sense of how long this strategy has actually been out there. And I would sort of this will be one to follow and wait and see if for the publication, because I think for many of us, for Sonia's recent patient, for others, there's a situation where lenacapavir seems like the viable option when there's pre-existing rilpivirine resistance, but our knowledge base for the strength of that regimen is quite limited. So more lenacapavir. So this is an analysis of the Capella trial. I think this was the pharmaceutical sponsor themselves that did it. And I always forget which company makes this, but analysis of that original data. So the Capella trial was the heavily treatment experienced people living with HIV. And so recall that lenacapavir actually has on-label use in highly treatment experienced people, as well as for initiation, unlike cabopivirine. So in 12 of their 72 participants, again, that was a very small trial. So 17% of them had no fully active antiretroviral therapy in their optimized background regimen, or OBR, for the trial. Of these 12, 5 of them had no even partially active agents, and the remainder had 6 of them, and 2 partially active agents in their regimen. And so this comes to the point of whether lenacapavir what the barrier of lenacapavir is. I think Ethel had pushed back a couple of weeks ago on lenacapavir as not being a high barrier agent, which I think is a valid thing to do. And this is sort of looks at whether or not how well did lenacapavir do really when it had very, very little support. And so by the FDA snapshot analysis, 10 of the 12 were suppressed at least one of the study visits at week 26, 52, or 104, and 8 of the 12 were suppressed at all 3 visits. For even those who didn't achieve full suppression, the median decrease in HIV viral load was 2.34 log copies, and the mean increase in CD4 count was 105 cells per microliter. So for example, one of these patients who did not achieve, FDA snapshot viral suppression had a CD4 count that went over 500 from being around 100 during the period of the study. And so again, like speaking to some of the other patients we've talked about in the last year, where with some of these novel agents, even without achieving viral suppression, there seems to be substantial benefits to immune health. And how do we sort of factor that in as we think about what treatment success means? So this one, and then a few other ART studies that I thought were worth mentioning on the global scale. So there was, this is like kind of an amazing fact that it was done, but in Haiti, there was an open label trial of 290 people on a boosted PI plus 2 NRTIs as their second line regimen. And they were randomized to either continue that or switch to BIC-FTAF. No resistance assessment, thought likely to be high, and the 48-week results was that BIC-FTAF was non-inferior. Pro-viral resistance testing is ongoing. So basically, this is sort of for global policy of if you fail your first line and you are put on a boosted PI regimen, the first line being NNRTIs, can you switch to an integrase-based regimen? And this randomized trial conducted in extreme social unrest actually did demonstrate efficacy. This is similar to the data that was published in the New England Journal last year in Kenya. The 2SD study, which was 795 individuals, similarly on second-line ART with a PI, were randomized to dolutegravir plus 2 NRTIs or to continue, again with no resistance assessment, and again at 48 weeks non-inferior. So just a comment on some things that are in the pipeline. There's a new compound with similar mechanism of action of islatravir, so a nucleoside reverse transcription translocation inhibitor that's being developed, a new integrase inhibitor. They were both asked questions about resistance patterns and whether they would be overlapping with existing agents, and it was a little bit unclear. A new NNRTI in development, weekly islatravir plus lenacapavir versus continued BIC-FTAF was done in a phase 2 study of 106 participants. No resistance, no decline in CD4 lymphocyte counts, and maintained suppression. And Biktarvy plus lenacapavir as a once-a-day regimen was studied, so oral regimen once a day. We think of lenacapavir being beneficial predominantly in its long-acting formulation, but it also has an oral formulation. And this is going to be done in a single tablet regimen, an STR, coming. Just to note here that the BIC dosing in this was 75, which is not the Biktarvy dosing. There was a bunch of studies on broadly neutralizing antibodies. All of these remain limited by baseline resistance to the antibodies, anti-drug antibody, and but still there's ongoing development and some optimization of these approaches. And I think, just the weekly islatravir lenacapavir study for me was sort of like, well, who wants that? And I was humbled by This is from Paul. He referenced this paper, which is in OFID in 2018, which was conducted at Duke and the University of South Carolina, where they asked 263 people who were living with HIV if they were going to change, if they would like to change to a single pill once a week, 2 shots in clinic every other month, or implantable rods like a Nexplanon type of model every 6 months. And 66% of the participants were very interested in 1 pill once a week. This was further emphasized by the SEARCH study, which was presented at CROI this year. It was a dynamic choice for PrEP options, so people could change and choose exactly what they wanted to do for their HIV prevention modalities. And it promoted PrEP uptake substantially, with substantially higher rates of use and no infections in the dynamic choice arm. And this was very reminiscent of the Polk lecture that Sharon Hillier gave here in, I believe, 2019, where she just made this very clear argument for how choice will enhance people's adherence because they have the ability to choose the things that work for them. So I guess that was so we'll see. Weekly islatravir, lenacapavir may be very interesting to lots of people. And we'll await more data to see whether that continues to show efficacy and safety. The last thing I'll cover for today, since we're coming up on time, is an analysis of what to do with archived genotypes. So this was another industry-sponsored trial So this was in prior trials of Biktarvy. So, and I think, I forget the manufacturer, but I think it's Gilead. And so people living with HIV, N equals 242, virologic suppression for greater than or equal to, not plus, 3 to 6 months, no prior failure on an INSTI regimen, which was part of the inclusion criteria, or no prior viral load greater than 400 copies, because being less than 400 can trigger a failure, but in one of the trials, you were allowed to be enrolled even if you had a viral load of less than 400. Genotyping with HIV RNA, and so that of those people, they included those who had genotyping of HIV RNA or proviral on more than or equal to 2 time points prior to switch in therapy. So they're looking for people who had resistance data before they switched. They had 2 time points for this resistance data on 223 of those participants and more than 2 for 26 of the participants. And they categorized in the 2 time point group as if a resistance mutation was identified, it was identified 100% of the time, or it was detected 50% of the time, because either you saw it both times or you didn't. And then in the multiple time points, they characterized them different patterns, so they could be persistent, detected every time it was measured. It could be detected and then not detected, which was a loss of detection, a gain in detection, or variable, meaning you had at least 3 different results over time. So what did they find? So in the 2 time point analysis, they had 262 resistance-associated mutations and 4,866 non-resistance substitutions. Only 39% of the resistance-associated mutations had 100% detection. This is almost exactly the same as the rate of detection of the M184V on proviral genotyping that was shown in that IAS abstract, where they were looking at the concordance of a known history of it, and then in a population that was enrolled when they repeated proviral genotyping, I think it was about 1/3 were consistently detected. In the 50% detection group, more were detected at time point 2. So it's not that resistance-associated mutations, even under viral suppression, go away with time. Rather, they see slightly more at time point 2. Not that that necessarily means that they're increasing. Non-resistant substitutions were more stable, and they were detected most of the time. But I will point out that the difference in numbers is an order of magnitude. So the stability of that group may be partially influenced by that. And the time difference between test 1 and test 2 was not different. It wasn't like if you waited 10 years, it was less likely to be the same. And if you waited fewer than that, then it was more likely to be stable. So the time difference for 100% detection, meaning both times it was seen, was 7.7 years, and 50% was 5.6 years. So actually closer together. In their multiple time point analysis, they had 64 resistance-associated mutations, and 45%, the plurality of them were variable detection, but and only 18.8% of them were detected at every single time point across the studies. So what do we do with this? So I think, we have a couple of things now to think about with respect to proviral resistance testing. So the CARES study, so that was that first Kitio abstract looking at cabrylpivirine in sub-Saharan Africa that had 8% CAB resistance and 10% rilpivirine resistance on proviral DNA. And there's also a prior paper in AIDS that suggests that detection of these proviral resistance mutations is more common on non-intact proviruses, which would make sense since those, as the siliconos have shown, are the vast majority of proviruses that are there. And that we can hold on one hand, so maybe it doesn't matter that much. But on the other hand, we have randomized controlled trial data from Atlas and FLAIR that CAB rilpivirine failure rate was impacted by proviral rilpivirine resistance mutations when they looked retrospectively. So I think that the answer to what we do with these is we're not sure. But I would love to hear other comments and thoughts from anyone else. We have like 1 minute left. And I have like 30 more slides. So no, did I see somebody? No? So I think I'll, in the absence of any further discussion today, I think there's a couple more things that we could talk about. There's some weight loss data, there's some updates on STI prevention that I'll tuck into one of these other sessions that we have upcoming. And then there's also some novel HIV-directed therapeutics, a little bit more from the basic science side, but I think of interest. So we'll sort of tuck those into the next couple of sessions. But thanks so much to everyone for your thoughts, and I will get working on a conditional incentive speaker to have for our group. Have a great weekend, everybody.